We have a bill on the agenda, which is House File 8. So I'm going to move that House File 8 be recommended to be re-referred to the Committee on the Commerce, Finance, and Policy Committee. And so let me just say a few words about House File 8, and then we have a list of testifiers here. So first of all, just to let people know that House File 8 is, as I said, going to go to the Commerce Committee, and then it's going to come back to this committee. So no one should think that what we're doing here today is the final word on the bill. This bill is going to be, it's kind of a work in process, but essentially what the bill does is it carves out the pharmacy benefit that you just all learned about and brings it all into the fee-for-service program. So if you recall from our overviews, about 75% of our program participants in our Minnesota public programs are under the managed care portion of the program. 25% are in fee-for-service, and DHS is managing their pharmacy benefit for that 25%, just as you've just heard it described by Mr. Hope. So what this bill does is it takes the rest of the pharmacy benefit away from the managed care organizations and brings it all together under DHS. And so this presentation today, this bill, it's essentially the same bill that was around in 2019. And so this is going to be part of the governor's budget proposal, although perhaps not the exact bill language. We haven't seen what the governor's bill language will be. And in fact, there was a bit of a tweak that was offered today, but it didn't make the deadline for amendments. So we're not bringing it into today's discussion. But this bill will be worked on. The other thing I want members to know is, although it doesn't have a companion right now, I'm sure I'll get that question from someone. I have discussed it with Senator Benson, and whether this is going to, I don't know if an exact companion will move through the Senate or not, but this bill will be in the mix at the end when we are doing our conference committee. So even though it right now the jackets haven't been filed on the Senate side, I expect that they will be, or at least this is going to be in discussion over there. So much for that piece of it. So what this does, as you've heard, or maybe you haven't heard this yet, but a lot of states are doing this. They are doing the carve out, and they're saving a lot of money. I think it's no secret that I'm a pretty big critic of the managed care system in our public programs, because what I think we're doing is taking a system that is pretty simple, where people come on our public programs, the public, out of taxpayer dollars, is paying for their health care when they qualify for our programs. And then we're paying a capitated amount to managed care organizations. And then after that, we, the legislators, have very little input into how these programs are managed. And there's a real lack of transparency as well. And this has been a long-standing problem. So this bill that's before you today is one little piece of saying we can manage the pharmacy benefit better all in one place than having it run through the various MCOs with their various kinds of rules, and each of them having a PBM to manage it for them, or having management expenses there to run the program. And even though we do have now this preferred drug list, we see that we can make this simpler for members, simpler for providers, instead of having to deal with multiple entities for different people who are all essentially on the same program, and that is our public health care program, medical assistance. They would deal with one entity. That would be the pharmacy management program in DHS. So instead of having to deal with multiple payers, if you will, all for under our public programs, this would simplify it for the pharmacy benefit. So also very importantly, this is projected to save quite a bit of money. And those of you on this committee know that we're facing a potential budget deficit right now. Under the current forecast, we don't know what's going to happen when we get the February forecast, but everybody knows that DHS or HHS, excuse me, Health and Human Services is always under pressure because a lot of money is spent in this space, and we should always be looking for ways to provide service that people need and to make it more efficient and less expensive to provide that service, because we will never have money enough to waste. And I believe that the savings from this program show that we are wasting some money. We can provide the service as well or even better and save money in the process. So we don't have exact fiscal estimates right now, but it is estimated to save somewhere around $20 million in the first biennium if we were to pass this bill. So much for that piece of it. The second piece, then one that I know there's some controversy about, is the second section of the bill. So the first section is, as I mentioned, pretty much the idea being the same one that was in the governor's budget last biennium, and we expect will be this time. But the second piece of the bill, section 2, simply says, this is not coming from the administration, this is coming from me, from the legislature and other members in the legislature. And the idea being that we would ask the Commissioner of Human Services to also take a look at this program and see if there's a way to expand the program to also make less expensive drugs available to a wider circle of Minnesotans. And I see from the letters we've received, that the committee has received, that there's a lot of controversy around this, but I just want to emphasize, all we're asking to do is have the commissioner look into it for us. So all of the kind of drama around what this would mean, and it's going to be like a disaster and all that, is kind of mysterious to me, because we're just asking to have the commissioner look at this and see if there's a way to do it. So with that, I'm going to invite some testifiers. And let's see here. First of all, I think that Mr. Hope might want to add to this. Mr. Hope, did you want to kind of complete your presentation, or are you done with and ready to move on?
Madam Chair, if it's all right, I believe our Assistant Commissioner, Matt Anderson, was going to speak to this part.
Okay, perfect. I think there might have been a couple more slides to show, and please feel free. So welcome to the committee, Commissioner Anderson.
Thank you, Madam Chair, and thank you, committee, for having me. As indicated, my name is Matt Anderson. I'm the Assistant Commissioner for Healthcare and State Medicaid Director at the Minnesota Department of Human Services. Pleased to be with you this afternoon and to be able to talk through some of the benefits of the proposal, as Chair Liebling had described. Again, as in any budget situation, even in good times, we are looking for ways, if we can manage our programs in ways that save money without reducing benefits or eligibility or any of the services that members receive. And this is one of those rare opportunities, one of those rare times where there was significant financial savings while at the same time providing our enrollees with the same or better services than what they're receiving today. As Chair Liebling indicated, this proposal was also considered by the Blue Ribbon Commission and is largely reflected in the proposals that Governor Walz included in his 2021 recommended budget. And that is basically taking the outpatient pharmacy benefit that Mr. Hope just described and administering it directly through DHS, through our fee-for-service program for all of our enrollees. Instead of right now, the system is, we're contracting with managed care organizations, 8 different managed care organizations. They are each contracting with their own pharmacy benefit managers, and we are managing those services through those different vehicles, splitting up the population and the spending accordingly. We have seen in recent years, as many of you know, that prescription drug pricing is driving up healthcare costs. This includes within our state public programs. So while our fee-for-service spending per enrollee has remained flat, I'm going to repeat that. Our fee-for-service per enrollee spending has remained flat. Our overall pharmacy spending per enrollee has increased 9.7% between 2018 and 2021. These increases have been significantly, obviously, much more rapid in our managed care pharmacy benefit, which is administered by pharmacy benefit managers, than in our fee-for-service system. Yet we lack the visibility into that drug pricing and operations by pharmacy benefit managers and how they're making their choices. So the proposal is to create a uniform system, one single system, to manage prescription drugs across all of our population, the fee-for-service and the managed care population. The Department of Human Services would align that pharmacy benefit across the population beginning in 2023 using the state's preferred drug list that Mr. Hope just described. And as part of that process would be using the Drug Formulary Committee, which he indicated has open public meetings, receives public comment, has an opportunity for the public to participate in the decision-making process. Unfortunately, it does not include, because of the federal prohibition, does not include the pricing information. And as Mr. Hope indicated, and as committee members already recognized, this is a significant barrier to transparency around drug pricing, and would be something that, if the federal law would change, that would make the Drug Formulary Committee and the information that would be available to the public even more transparent on the full spectrum of how these decisions are made. Enrollees, the public, providers would all have the ability under this proposal to be able to provide input into the pharmacy benefit for our enrollees, the ability to provide written and verbal comments, the ability to see how decisions are being made, who's voting for which proposals, and to be able to manage the pharmacy benefit in that much more transparent fashion. Next slide, please. As Chair Liebling indicated, several states already have or are exploring removing outpatient pharmacy benefits from their managed care contracts. Now, when you're looking at the map here, this is provided by the Kaiser Family Foundation based on 2019 contracts. The gray states either haven't responded to the survey or don't use managed care at all, so not really an issue there. The light blue states are the states that have carved out pharmacy benefits from their contracts. California and New York are in the process of doing this, and so hoping to get information from their experience. But as indicated earlier, West Virginia, after moving its pharmacy benefits to its fee-for-service program in July of 2017, has realized $54 million in savings. North Dakota, just in 1 year, moved its benefits to its fee-for-service and administered them in a single program, $6.4 million in savings in 2020. Obviously don't have all of the claims in yet for 2020, but for a state of its population, this is a significant savings. We expect to see even more dramatic numbers, obviously, with California and New York. And so again, we believe that this is something where we can provide a more uniform, public, transparent, and more efficient way of being able to manage drugs that our enrollees need without further limiting drugs that they have access to, without changing their medications, and without harming either enrollees or providers to be able to manage our system. And by doing that, we have a more efficient process, more cost-effective, better stewards of the public resources, and at the end of the day, hopefully easier to make the difficult budget decisions that the legislature is going to make. I'm going to take a moment just to respond to Representative Gruenhagen's earlier question around DHS becoming a pharmacy benefit manager under this proposal. And would just say, one, that we are not becoming a pharmacy benefit manager. If this proposal is adopted, we are exempted from pharmacy benefit licensure. We are not contracted. We are not taking a contract to administer a benefit that someone else is providing, and so therefore not a pharmacy benefit manager. But more importantly is the distinction between how DHS operates and a pharmacy benefit manager operates. So licensing aside, the biggest difference is we aren't operating the program for a profit. And so there's the significantly different motivations and different costs associated with that. And then second is today our enrollees have no idea and no way of finding out how pharmacy benefit managers are making decisions about the drugs that they are negotiating and purchasing and what kind of deals those are. Whereas in the DHS process, because of the Drug Formulary Committee process, because we answer to the legislature, that the process itself is much more public and transparent, and the public has an opportunity to actually influence that process and help make decisions. With that, I'll stand for questions or any other help that you would like, Representative Liebling, if there's ways that I can be of help.
Thank you very much for that, Mr. Anderson. And we do have a question from Representative Breyer. And so if there are other questions for you, we can take a few of those now, and then we'll go on to our other testifiers. And if you can hang around till the end, that would be great if there are additional questions after that. So Representative Breyer.
Thank you, Madam Chair, and thank you, Mr. Anderson. I appreciate this. I am no fan of extra layers of administrative costs being added, so I have appreciated hearing this plan. I have one simple question, I think. You mentioned that the fee-for-service per member cost has been flat, while overall it's gone up almost 10%. Is there any patient-based difference that would account for that, or are fee-for-service patients basically equivalent to managed care patients? It's kind of the case mix question. Thank you.
Commissioner Anderson.
Madam Chair, Representative, excellent question. Ironically, the fee-for-service population, statistically speaking, has higher acuity. It tends to be more medically complex patients, where pharmacy use you would expect to be more specialized and higher, and therefore I would say intuitively more likely to be seeing cost increases, and so there isn't at least from our analysis a way of being able to explain the difference in cost rate growth based on the difference between the fee-for-service population and the managed care populations.
Representative Breyer?
Yeah, fascinating. Thank you very much.
Thank you. I've got Bierman and then Ackland. Representative Bierman.
Thank you, Madam Chair, and thank you, Commissioner Anderson, for being here. I want to especially thank you for laying out that difference between this process with DHS and PBMs. Those are significant, and I think for everyone in the committee, that really kind of sets the floor on the change we're making, and it fits right into what I hear most people want to do. They want to make it more transparent. They want to have that ability to see and participate directly to the legislature, and I think that was one of the best points I've heard today. I learned from Rep. Pulowski the other day that in order to teach his students, he always repeated everything 3 times. So I've done it twice. If someone else could do it, we would be set for the day. But my question then is, wondering on the carve-outs with other states, if you have any updated data on Wisconsin at this point, and if so, that would be an interesting mark to have. Thank you so much.
Commissioner Anderson.
Thank you, Madam Chair. I don't have any additional information on Wisconsin at my fingertips, but I will look into that. We'll do some research, and I'll contact our peers over there and see if they have some data they can share with us and get that to the committee after the hearing.
Thank you, Chair Liebling. Thank you, Commissioner.
Thank you, Commissioner. It is very impressive that North Dakota is doing this, not a hotbed of liberalism. and yet they are doing this and saving money. That is impressive. Representative Auckland.
Hi. Commissioner Anderson, I have just a quick question back to the federal law prohibits the state Medicaid programs from talking about drug prices and rebate amounts. I'm wondering, are the current managed care organization or these PBMs, are they under the same restriction not to talk about pricing?
Commissioner Anderson.
Madam Chair, Representative, I don't know if the same restriction applies, and so I'm going to ask Mr. Hope if he can weigh in with any additional detail on that. I will say, however, that the managed care organizations and pharmacy benefit manager organizations regard this information as trade secret or proprietary information. So even if the federal gag rule didn't apply to them, they would not disclose that information as protected intellectual property.
Mr. Hope.
Madam Chair, Representative, thank you. It's my understanding that that prohibition applies specifically to the state Medicaid agencies, so DHS. And I can confirm that we don't even share the rebate information with the managed care organizations. We're not allowed to do that. So they don't have the information that they're prohibited from sharing if it did apply to them. As far as the PBMs sharing their own cost or rebate information, I believe Assistant Commissioner Anderson is correct. They would view that as trade secret, but I do not believe that they are prohibited from sharing it if they had chosen to do so.
Thank you.
Representative Ackland. Okay.
Thank you very much.
All right. And Representative Ackland, I know, being new, I don't know if you already would know this, but there's a long-standing kind of heartburn in the legislature among many members on both sides of the aisle about the lack of transparency of what we're doing with our MCOs generally. So I think that we talked about this in a previous meeting of this committee, that if you want to find out how much is paid for a primary care visit under one of the MCOs in our public programs, you cannot find out because they consider that proprietary. There in fact was a law passed to try to make that transparent, and still it isn't transparent. So this is a long-standing problem even outside of the pharmacy area. But thank you for your question.
And I thank you for that explanation too, because it is troubling to me, hearing about it. So.
Well, yes. And I mean, we as legislators manage these programs. It's a lot of money. Mm-hmm. And our constituents believe that we're in charge. And yet we can't even find out what a provider is being paid. And there is something very troubling about that. So, Representative Bonner.
Thank you, Madam Chair. So I have a question, and I suspect it is for Mr. Hope. But the earlier question was asked about prior authorization, and we specifically called out that there was sort of a pathway for folks who are already in the system who may be on a medication for some sort of a condition, a chronic condition, correct? And that there may be a pathway so that if the formulary were to change, it would help sort of streamline that process for them. But what I didn't hear, and maybe I missed it, is I'm curious if someone is coming from outside of that pool, right? So they're not in the 75% MCO pool, they're not in our little 25% fee for service pool, but they're now entering the system. And they've been taking, and I'll just throw out an option. So let's say you're taking a specific blood pressure medication or a specific medication for diabetes, and you now enter the system, that you've been on that medication for some time and it's been working well for you, but now it is no longer on the preferred list. Is there some pathway to help streamline the process for those folks? Primarily, and I will tell you in full disclosure, I worked at one point for an organization that did authorize drugs for a living, and a lot of patients would come in, they'd go from one plan to another, and they'd been on, say, a medication for 10 years. And now going to the new health plan, they would have to try and prove that they had tried and failed 2 other medications. So we were taking them off something we knew worked to jump through some hoops. And so I'm just curious if there's a pathway for that as well.
Mr. Hope?
Madam Chair, Representative. So there is a pathway to the non-preferred drugs. As I mentioned before, there's both a continuation of therapy override as well as the non-preferred drug criteria. The continuation of therapy override would allow for a prior authorization to be approved for up to 90 days in the event that someone was on that medication coming in and new to the plan. So for example, say they had commercial insurance and they were on a product and then they were coming to the public programs. That's certainly something that we know happens and we're aware of, and we may not have that claim history. As far as the criteria itself getting to the non-preferred drug, they may or may not be able to satisfy that criteria automatically. I don't want to paint false promises there, but there are considerations in that criteria for instances where, you know, the member would not be a candidate for the preferred drugs. But we also have to take into consideration that medications within the public programs where we have the federal Medicaid drug rebate and commercial plans, there can be very different cost structures associated with that. You know, for example, the PBMs may be preferring the higher cost brand name drugs for different reasons in the commercial space, whereas the cost for the public programs are very different. So it's not an automatic, but it's certainly something that we've tried to account for in the criteria itself, so that members are not just moved around for no reason, because disrupting someone's drug therapy is not something that we take lightly.
Okay, thank you. And, you know, we're going to go to Representative Backer, and then we're going to go to our other testifiers, because we do have 3 other testifiers. Representative Backer.
Thank you, Chair. Just a quick question here. I want to make sure I'm on the right page. Where I am understanding, because we are talking about that there's cost savings in this bill. The cost savings in this bill is, from what I understand, isn't about lowering drug costs. It's really the budget savings in the administration costs by not paying managed care organizations to provide a service to the state. Am I on the same page on this?
Commissioner Anderson?
Madam Chair, Representative, you are on the right page in terms of the fiscal cost savings that we are estimating is from administrative savings. In doing that, we think we do not include projected savings that may result from the ability of the state to negotiate prices with a larger pool of enrollees. As we gain volume, we expect that our negotiating position would increase, but any advantage that we would have in negotiations are not factored into the fiscal cost of this. So this is a administrative savings that, as you indicated, that from being able to carve out the portion that we are paying to managed care organizations, and they are in turn subcontracting to pharmacy benefit managers, that we would be saving.
And Representative Backer, that's an excellent question. Thank you for asking that. I just want to jump in to point out that we don't have an actual fiscal note right now today, but the bill is coming back. And when we have a fiscal note for it, I think we'll be able to see as a committee more precisely where the savings are projected.
One more comment.
Please, go ahead.
You know, for this to work here, and other states have maybe seen the success, like you put it out there, Chair, leaving North Dakota, I'm glad they do, but there has to be a level of trust, you know, between everybody, that information, when you take away the administration of looking it over, managing it, then fingers can get in the wrong pot, and things can get, what we say in Western Minnesota, get legs and walk away. So I'm assuming one of the reasons North Dakota has been so good is they're trusting people, and their yes is their yes, and there's no's there's no. So just something for us to think about when it comes back.
Well, okay. I mean, thank you, Representative Backer. I certainly, you know, what I would say is that oversight of the MCOs and oversight of this whole program is a constant ongoing issue, right? And the more complex the program is, the harder that is to accomplish. So I take your point, but if you're sort of implying, and I don't know that you are, that the MCOs are somehow more honest and trustworthy than the people who work for DHS, I guess I would, you know, I'll fight you on that one. I don't think we should assume, and I'm sure you're not, but
No, I'm not.
you know, but of course, you know, but
No, and it's a fair,
yeah,
Chair, that's very fair. It's just when you take it, I run a business, and when the cat's away, the mice can play. I'm not saying that's going to happen in this scenario. As committee members, we just have to look at, is that a potential? That's all I'm saying. And my implication is not that one's better than the other one. It's just a concern that could be it. So I appreciate you bringing it up. We're on the same page because I'm not trying to imply anything.
yeah. Thank you. Thank you very much, Representative Backer. Okay, let's go now to Dan Andreessen from the Council of Health Plans. Mr. Andreessen, welcome.
Thank you, Madam Chair, members of the committee. Again, my name is Dan Andreessen. I'm with the Minnesota Council of Health Plans, the trade association for Minnesota's 7 nonprofit plans. Thank you for the opportunity to testify on this bill today. The council is concerned about the approach to carve out pharmacy benefits from Minnesota healthcare programs. Managed care is most effective when care and utilization management extend across all healthcare services. Prescription drugs are a central component of these services, and carving them out will remove vital opportunities to coordinate care. We're also concerned about the likely increased cost of this approach, given the experience of pharmaceutical carve-outs. The use of lower cost generic drugs leads to lower overall costs, but it also tends to lead to lower rebates per prescription to the purchaser. Under a carve-out approach, we have seen other states use a lower percentage of generic medications and instead negotiate for more rebates per prescription on brand name drugs. This rebate maximization strategy typically leads to a higher average net cost per prescription. And lastly, we're confused by the language granting DHS the authority to create a preferred drug list, given as we've been talking about, they've already done this work. Starting in 2019, all managed care organizations had to adopt DHS's preferred drug list across all public programs. And this change was made through the contracting process without legislative input. We've gone from a program that has 9 formularies to 1, which thereby reduces consumer choice. The new system has created confusion as a significant number of enrollees have faced multiple switches between medications as they must now adhere to a new formulary that divides drugs into preferred and non-preferred. Now, all drugs may be covered, but not access to all drugs are equal. In 2020, appeals nearly doubled from the previous year as enrollees sought to maintain access to their existing medications. And some Minnesota Care enrollees have paid more for their medications because DHS requires a higher out-of-pocket cost for name brand drugs rather than generics. If this proposal continues forward, we urge the committee to look into the current costs associated with the preferred drug list over this past 19 months. But more importantly, talk to state public program enrollees and consumer advocacy groups to hear how this change has impacted them when it comes to their enrollee cross-sharing and access to prescription drugs. Thank you.
Okay, thank you. Questions from members for Mr. Andreessen? Okay, I'm not seeing any right now, but Mr. Andreessen, if you could hang on there, there may be some. Peter Felstad from Pharma.
Yes, thank you,
Yeah,
Madam Chair.
welcome.
Chair, can you hear me okay?
Yes.
Thank you. Chair Liebling and members of the committee, good afternoon. My name's Peter Fjellstad. I'm a Senior Director of State Policy for Pharma, the trade organization for 33 biopharmaceutical manufacturers that make brand name medicines that save and improve lives every day for patients. Over half of our member companies are currently making treatments or vaccines for COVID-19, with 15 clinical trials for COVID treatments or vaccines going on right now in Minnesota. Today, I respectfully oppose House File 8, which would create a prescription drug purchasing program for Medicaid and Minnesota Care populations. Pharma does not oppose what is often termed as bulk purchasing for non-Medicaid populations, but we do oppose efforts to include Medicaid populations in aggregate purchasing programs with other state public programs or any other private or public entity. First, Minnesota does not have the authority to require Medicaid rebates for non-Medicaid populations if there are no Medicaid expenditures. Second, Medicaid may be leveraged to obtain rebates for non-Medicaid populations when doing so benefits the Medicaid population as a whole and/or increases the efficiency and economy of the program, the Medicaid program. Third, Minnesota's burden to show that combining Medicaid and non-Medicaid lives will meet CMS requirements is tremendous in terms of costs and overall resources. Right now, I know that we don't have a fiscal note, but without funding, it's unclear how DHS will be able to complete that necessary research to identify how this proposal will sufficiently benefit the Medicaid population as a whole, as well as demonstrate efficiency and economy in Medicaid. If the concern of this bill is to address prescription drug access or costs for Minnesotans, we do not believe that it is effective. The Medical Assistance Tool, or www.mat.org, is an online tool of more than 950 industry patient assistance programs for those patients that cannot afford their medications. I've submitted a document to the committee regarding this tool. In closing, I'd just like to thank you, Chair Liebling, for the opportunity to testify on your bill and the committee members for your time today. For all the reasons I've laid out, I respectfully oppose House File 8, and I ask for your no vote. I'd be happy to answer any questions.
All right, thank you, Mr. Fjellstad. I don't see any questions. Oh, I do see one. Representative Bierman.
Thank you, Madam Chair. Thank you, Mr. Fjellstad, for coming and speaking today. And I'm just curious what the results have been in other states that have already done this carve out, and whether you have seen or how have those other states handled these issues that you brought up in the letter pertaining to us making this change here in Minnesota.
Mr. Fjellstad.
Chair Liebling, Representative Bierman, I think that there's a few different issues going on with this, the language in this bill. I know, Chair, that you had mentioned that you thought some of the letters might be getting the cart before the horse with regards to how they responded to the language. Right now, the language in House File 8 is most similar to provisions that passed in California's budget in 2020, back in May. And those provisions actually set up a similar type of program, but nothing has been done for the program that was seeking to leverage Medicaid rebates for a greater population in the state. Other than that, there's been no states that have passed specifically those types of programs. As far as a carve out to switch from from managed care to fee for service, that's completely accurate. All the prior discussion with West Virginia and other states, that has happened there. But speaking directly to what we view this most akin to, which is what happened in California, and that has not been operational yet.
Very good. Thank you, Madam Chair.
Okay, thank you, Representative Bierman. So I have Grunhagen, then Ryer, then we're going to go to our last testifier, and then we'll have more time for questions, I hope. Representative Grunhagen.
Oh, thank you, Madam Chair. My question is for Mr. Fjellstad, too. He touched on one of the areas of concern, and I have not been a fan of PBMs. When you said bipartisan concern, I would agree with that, Chair Liebling. So I think there's some concerns to address there. But Mr. Fjellstad, if you'd address again this idea of coordinated care and losing the ability to keep prescription drugs as part of addressing the coordinated care for individuals. Our staff member for our committee here said there was a study that some state that went to this, 25% of recipients of the Medicaid had worse healthcare outcomes by going to a closed formulary. So I just would like you to reiterate the concern about coordinated care, and if you're aware of that study that 25% of Medicaid recipients where they went to this type of change actually had worse healthcare outcomes.
So Representative Grunhagen, I think that question probably would be addressed to Mr. Andreessen, because I think he was the one who said that.
Oh,
And,
okay.
and so if you would want to hold that question till the end, because I want to make sure that all our testifiers have an opportunity, and then we can circle back to the ones who've already spoken. I mean, Mr. Fjellstedt, if you want to answer that, you may, but I don't think that was really something you brought up.
Yeah, I'm happy to review any studies. Chair Liebling, Representative Grunhagen, happy to review any studies. I have not seen that the 25%. I'm not sure which state, so that I can't speak to it. I'm sorry.
Okay, and then Representative Ryer, I think do you still want to speak?
Yep, I took my hand down. Thank
Okay,
you.
very good. Okay, so we'll move on then to Sarah Durr. Ms. Durr, welcome to the committee. Please introduce yourself and go ahead.
Madam Chair, members of the committee, my name is Sarah Durr, and I'm a pharmacist by training and serve as the executive director of the Minnesota Pharmacists Association. Thank you for reintroducing this important proposal that Minnesota Pharmacy believes can make a difference in patient lives, general stability for providers, and save the state and taxpayers millions of dollars. House File 8 would eliminate the managed care and commercial pharmacy benefit managers from management of medical assistance drug spend and move to a direct fee-for-service drug spend model. Currently, 28 states have implemented a direct fee-for-service Medicaid drug spend model. An additional 12 states, including ours, are now contemplating the elimination of their state's use of an MCO to manage their Medicaid drug spend. Today, Minnesota has about 75% of MA drug spend managed underneath the PBMs through their MCOs, as you've heard previously today. One example, as we've mentioned, is West Virginia, where the Medicaid agency started managing the prescription drug benefit directly in 2017. As Dr. Hope mentioned earlier, West Virginia has saved $54.4 million in the first year and continue to save into 2020. Recent studies on Medicaid managed care programs in Ohio, New York, and Pennsylvania have indicated that PBMs are overcharging taxpayers for their services in Medicaid managed care, reimbursing pharmacies at a lower rate, and billing the state Medicaid program at a higher cost for medications, as well as retaining the difference. The promise that PBMs were going to save states money has not been realized. And in fact, based on a 2019 Minnesota Management and Budget Fiscal Note and the current savings for this proposal in the recently released governor's budget, we know that the state, Minnesota citizens, and healthcare providers will all do better under this model. We support HF8's premise and promise. However, any move to 100% fee-for-service model will also need to account for patient access and provider compensation. Relying on transparent, reasonable, and mutually agreed upon provider reimbursement while keeping the patient's best interests in mind will be essential to successfully and efficiently look at our drug spend for the MA population. Thank you. I'm happy to answer any questions, and my testimony was sent to members of the committee and has additional links and information in it.
Great. Well, thank you very much, Ms. Durr. And since I'm not seeing any other questions, I will ask you a question. Right now, as well, in our opening presentation, it was explained that these patients are mostly getting their drugs through a pharmacy, and then the pharmacy is being reimbursed through whichever program they're in under the public programs, right? So from the point of view of a pharmacist, we hear a lot that a lot of our small pharmacists are really struggling, that we're having trouble keeping pharmacies alive, and especially in rural parts of the state. And so from the point of view of a pharmacist, how do you see this? Well, let me just kind of even give you a little more of what I'm thinking. Right now, you essentially have to take the reimbursement from whichever one of the MCOs is covering that patient, right? And if those reimbursements are not enough, I don't know if you're just stuck, I assume. And if we were to go to this fee-for-service model, all fee-for-service, I think you're saying potentially we could still have reimbursements that are too low, but at least you would kind of have one entity to deal with to try to drive those up. Is that accurate? Could you just talk a little bit about from the point of view of the pharmacist who's trying to survive on the reimbursements, how this all looks?
Yeah, Madam Chair, thank you for that question. It definitely is challenging right now for us with the PBMs working through the MCOs. We are getting clawbacks. And for those of you that don't understand what that is, we get retroactive fees that come to the pharmacy months, even up to a year later, and the pharmacy doesn't know that's coming. And so a lot of our small pharmacies cannot keep their doors open with the current model that we have in place. And so I do agree with you, Madam Chair. I think if we were dealing with one entity, we would have a better chance of being able to make sure that we are expressing the pharmacy's concerns, that we are having the correct reimbursement, which we are not currently having happen with all of the PBMs. And that would actually help us keep those pharmacy doors open. And I would just add that our rural pharmacies are really key to those that need healthcare. Most patients live within 5 minutes of a pharmacy. They may not live within 5 minutes of a clinic. And so I think we really need to think about how we can keep these pharmacy doors open and that we're not charging these pharmacies or taking fees back from them months later that they don't see coming.
Okay, well, thank you so much, Mr. So we had that question from Representative Grunhagen to Mr. Andreessen, I think, and I see your hand up there, Representative Grunhagen. Is that why? And we can ask him to answer the question. I'm sure he heard the question.
Oh, I'd have a question for the pharmacy.
Okay. Why don't you ask her that one first, and then we'll go to Mr. Andreessen.
Oh, thank you, Madam. Yeah, I don't think this bill includes any increase in reimbursement to pharmacies, as I see it. Maybe that'll change, but right now I think it's just $1.50. Would you agree with that?
Ms. Durer?
Sure, on the $1.50 piece, and I agree. I don't think that it includes an increase, but I think it's a more transparent model so that we actually know what we're being charged for a medication versus right now the PBMs are very non-transparent, and we've tried to change that with 62W that was passed in 2019. However, that is not fully enacted yet through the Commerce Department.
Representative Grunhagen?
Okay, thank you. And then if Mr. Andreessen would respond to my previous question.
Sure. Mr. Andreessen?
Madam Chair, Representative Grunhagen, stop me if I don't answer your question, if I misremember it.
It had to do with coordination of care and remove the drug plan, and that there was a study that showed that when you remove the drug plan, you have 25% worse healthcare outcomes. And that was, are you aware of that?
Mr. Andreessen.
Madam Chair, Representative Grunhagen, I don't know if I have that number of, what state that is, but we have seen situations where, you pull a piece out of that coordination of care, that there's some misinformation that happens between, the MCO that's working with that enrollee, and now that other piece of that puzzle is now being, essentially managed and operated by another entity. And so we do have concerns about what this can mean for the enrollee experience when it comes to how they're working with maybe their chronic disease or their situations.
Okay, thank you for that. So members, we're going to move to a vote very shortly here on the bill. Are there any further discussion that members want to have or? Okay, and seeing none, I see Representative Grunhagen's hand is up. Before we go to you, did DHS want to comment? Commissioner Anderson, did you want to respond at all on this issue about health outcomes, and does DHS have any thought on that?
Madam Chair, would appreciate being able to see the study that's being referenced. We aren't aware of significant quality outcomes changes in states that have moved from a managed care model to a fee-for-service model. And I would say that we already share a significant amount of claims information with managed care organizations, particularly from federally qualified health centers or Indian Health Services to help with care coordination. We would plan to do the same thing with the pharmacy as someone gets their prescriptions filled or claims come in to be able to help with care coordination.
Okay, thank you for that. Okay, further discussion. Representative Pryor.
So Well, first of all, that, I understand that this is our first stop and that more work and more discussion and that we'll be able to keep working with it. So I am going to vote yes, because I think that this is something that needs to be pursued. And then just kind of on a general sense with that understanding, the nuts and bolts of how things come together. But we've certainly in the legislature, we've heard concerns about people getting access to the medication that they need when they need it and not have to go through lots of trials when they know that what works. And, we're talking about MS as one of those illnesses where when you have something that works, you want to stay with it. So I guess at some point, I would just want to hear that kind of comparison of if we are doing this carve out and we do have this system of having a pre-authorization or the preferred list, how we would be, best protecting the health and not just the cost of drugs to the state, but to the health of the people that are receiving these prescriptions. So maybe that's not something that we, have time in this committee to answer definitively right now, but just something that certainly would be my concern and something I would want to be able to, represent my constituents and say, yeah, this is a strong way forward, that we are going to make sure that people have access to the medications that they need when they need it.
Okay, thank you. And we do need to move to a vote. I don't know, I think Mr. Anderson might want to respond, but let me just say this, folks. This is the first stop for the bill. It's going to go to Commerce. It's going to come back. If you have a concern, please contact me. We can amend the bill. This is not a done thing. And if there are issues that concerns that need to be more fleshed out in the bill, I'm completely open to that. So this is just a stop on the way. And I'm sure that, when we see the language to, I hope we will soon, what DHS actually has, because they're, what I've got here in the bill isn't necessarily their final language either. So appreciate that comment. Representative Pryor. Okay, really briefly, Representative Gruenhagen, and then we're going to move to a vote.
Oh, thank you, Madam Chair. I'll be brief. The name of the study is Do Formulary Drug Exclusions Save Money as Promised? And it was in the AJMC. So we could forward that to committee members. Again, it really needs to be fleshed out that we're not hurting the treatment here. And I have a lot of concerns about PBMs, but I also want to make sure the patients get the coordinated care that they need. Thank you, Madam Chair.
All right. Thank you, Representative Gruenhagen. If you would send that to Patrick McQuillan, our CA, he can get that out to the committee. And I'm sure we'll be talking more about this. So with that, members, I renew my motion that House File 8 be recommended to be re-referred to the Commerce, Finance, and Policy Committee. So with that, Ms. Niederhofer, please take the roll.
Chair Liebling.
Aye.
Vice Chair Hewitt.
Aye.
Minority Leader Schumacher.
Schumacher, no.
Representative Ackland.
Ackland, no.
Representative Backer.
Backer, no. Backer votes no. Did you get that?
Okay, Backer, no.
Yeah, thank you.
Okay. Representative Bonner.
Bonner, aye.
Bonner, aye. Representative Bierman.
Bierman, aye.
Bierman, aye. Representative Bolden.
Bolden, aye.
Bolden, aye. Representative Damath.
Damath, no.
Damath, no. Representative Freiberg.
Yes.
Freiberg, aye. Representative Gruenhagen.
Reluctantly, no. I need more information.
Representative Keel.
Keel, no.
Keel, no. Representative Morrison.
Morrison, aye.
Morrison, aye. Representative Munson.
Munson, no.
Munson, no. Representative Pryor.
Aye.
Pryor, aye. Representative Quam.
Quam, no.
Quam, no. Representative Ryer.
Pryor, aye.
Ryer, aye. Representative Schultz.
Schultz, aye.
Schultz, aye. Representative Wolgamott.
Wolgamott, aye.
Wolgamott, aye. That's 11 ayes and 8 nays.
All right, there being 11 ayes and 8 nays, the motion prevails and the bill is on its way to the Commerce Committee.